The entire cardiac output passes through the lungs every minute, yet pulmonary artery pressures are only a fraction of systemic pressures. Why? And why can a small blood clot suddenly become life-threatening? To answer these questions, we need to understand pulmonary circulation. Pulmonary circulation begins when deoxygenated blood leaves the right ventricle through the pulmonary artery. Unlike systemic arteries, pulmonary arteries carry deoxygenated blood. The blood travels through progressively smaller vessels until it reaches the pulmonary capillaries surrounding the alveoli. Gas exchange occurs across the alveolar capillary membrane. Oxygen enters blood, carbon dioxide leaves blood. The oxygenated blood then returns to the left atrium through the pulmonary veins. One of the most important features of pulmonary circulation is its low pressure. Normal pulmonary artery pressure is approximately 25 by 8 mm with a mean pressure around 15. Compare this with a systemic arterial pressure of roughly 120 by 80. The pulmonary circulation receives the same cardiac output but operates at much lower pressure. How? Because pulmonary vascular resistance is extremely low. The vessels are thin, compliant, and capable of accommodating large increases in blood flow. During exercise, cardiac output may increase 4 to 6 folds, yet pulmonary artery pressure rises only minimally. This occurs because additional capillaries are recruited and existing vessels dilate. These mechanisms maintain low resistance despite increased flow. Now let's discuss pulmonary vascular resistance. Resistance is influenced by vessel diameter. Small changes in radius produce major changes in resistance. Hypoxia plays a unique role here. In systemic circulation, hypoxia causes vasodilation. In pulmonary circulation, hypoxia causes vasoconstriction. This phenomena is called hypoxic pulmonary vasoconstriction. Its purpose is to redirect blood away from poorly ventilated alveoli towards better ventilated regions. This improves ventilation perfusion matching. However, chronic hypoxia can become harmful. Patients with COPD, interstitial lung disease, and sleep apnea may develop widespread pulmonary vasoconstriction. Over time, pulmonary vascular resistance increases. Pulmonary hypertension develops. The right ventricle must work harder. Eventually, right-sided heart failure may occur. This condition is known as Cor Pulmonale. Blood flow is not evenly distributed throughout the lung. Gravity influences pulmonary perfusion. At the lung apex, blood flow is lower. At the lung base, blood flow is higher. This creates the famous West zones. Zone 1. Alveolar pressure exceeds arterial pressure. Zone 2. Arterial pressure exceeds alveolar pressure, but venous pressure does not. Zone 3. Both arterial and venous pressures exceed alveolar pressure. Most healthy lungs primarily operate in Zone 3. Understanding these zones becomes particularly important in mechanical ventilation and shock states. Pulmonary embolism increases pulmonary vascular resistance. ARDS disrupts pulmonary circulation. COPD causes chronic hypoxic vasoconstriction. Pulmonary hypertension increases right ventricular workload. All of these diseases begin with alterations in normal pulmonary hemodynamics. The pulmonary circulation is not merely a transport system. It actively regulates blood flow, optimizes gas exchange, and determines right ventricular workload. Understanding it is essential for every intensivist.